There we go. Okay. I'm about ready to do it. So if you want to hide your face, more than welcome to. Huh? Back here. You gotta go back here. Can you see, Dave? Yep. You need to clean your glasses real quick so you can hear? We're good. All right. All right, let's knock this out of the way real quick. Raise your hands or something. I don't care. Yeah, I can't see anybody here. Yeah, you can do that too. I don't give a shit, Mandy. As long as I get you, as long as I can physically prove you're here, that's fine by me. Yeah. It's not going on YouTube or anything like that. Don't worry about it. Anyway, guys, today's topic that I'm going to be covering is the STEMI. But before we get into that, we're going to just cover the basic anatomy of the heart, the basic physiology of the heart. We're going to kind of go over EKGs a little bit, and then we'll discuss the topic at hand. The only reason I'm covering this is I could get up here, show you a picture of a STEMI, and say, hey, guys, that's a STEMI. Send you out in the field, and you'd probably see it and be like, oh, yeah, that's what it is, because I remember what it looks like. But you probably wouldn't have any idea of exactly what's going on with the heart. So that's why it's important to cover the anatomy, physiology, and an EKG real quick. All right, statistically speaking, according to the American Heart Association, 720,000 people suffer a heart attack each year. Every 34 seconds, so in the span of my little spiel here, someone is going to have a STEMI. Somewhere, somehow in this United States alone, will have one. Every 60 seconds, so every minute, someone dies from one. So these things are very serious. It's something not to be taken lightly. It's a very, very serious condition. The number one killer, obviously, is heart disease, and STEMIs are a variation of heart disease. Okay, so the basic anatomy, as we all know. Oh, hold on a second here. Skipped over a slide. Oh, there we go. Here's a basic picture of the heart. You know, you got the two atriums, the left and right ventricles, your superior and inferior vena cava, your aorta, pulmonary artery, and your pulmonary vein. It's kind of in a nutshell the bare bones basic of the heart. I'm not going to get into all the various cardiac muscle and tissue and all that stuff. Just kind of something useful to have in your mind. The basic flow of the blood, you know, you have the blood coming in through the superior and inferior vena cava, into the right atrium, and, you know, obviously the blood is deoxygenated at this point. It flows through the tricuspid valve into the right ventricle, then from there to the pulmonary artery, which brings it to the lungs for oxygenation. Then it returns via the vein into the left atrium, and then we have it flowing into the left ventricle, into the aorta, and throughout the body. Now, like I said, and I can't say this enough, this is a very, very bare bones overview of the physiology. I'm not going to get into voltage gate channels and, you know, things leaking across and all the other various things that I could probably give an entire presentation on. I know Sam's tired, so I'm going to keep this pithy. Right on. All right. So anyway, the resting period of a cardiac cell is negative 90 millivolts. The only reason I bring that up is the resting volt of, let's just say, a neuron or any other cell is typically negative 70. So, you know, that's the reason I brought it up. A cardiac cell has a much lower resting potential than any other cell in the body. The threshold potential, which is about where a cell will depolarize, is at negative 70 millivolts. So, like I said, a neuron, your neurons in your brain and everything at negative 70 are at their resting potential. With the heart, they're actually at their point where they can depolarize. Okay, yeah. Anyway, the cardiac cells themselves do not need external stimulation to actually contract to do their job. These are autonomous. They operate on their own. So basically what we have is the potassium is flowing out of the cell at a greater rate than the calcium that's flowing into the cell. So you have a net negative, which is why the cell returns from a positive value when it fires to a negative 90 millivolts. It's called repolarization, and the cell is now ready to do its cycle one more time. I'm not going to bore you by going into all this, but it's kind of important to know the absolute refractory period. It's basically after the cell has fired its impulse, it is not susceptible to any impulse. So if the SA node fires off an abnormal pulse and the AV node is in its absolute refractory period, nothing's going to happen. The impulse is just going to stop right there. Effective refractory period, basically it can cause a minimal depolarization, but it will not affect its neighboring cell. So we have a relative refractory period and the supernormal period. You know, these are just as the cell is depolarizing back to its resting state. These are some of the other periods that it will go through. Here's basically, you know, just kind of an overview of what I was talking about, the various phases of the refractory period. I'm not going to get into all this stuff right now at this point. And here's how the refractory period relates to the PQRST complex itself. You know, so that's basically what's going on there during the refractory period, like the negative 90 is your P wave right here and whatnot. So now with the heart itself, you know, you have the SA node that is the first one. It's the heart's pacemaker. It travels from the SA typically to the AV node in a heart that's functioning correctly. We're just looking at this from a normal functioning perspective, not an abnormal one like AFib or VFib or anything else. We're looking at a healthy heart. So you have the SA node to the AV node, which there's a little bit of a lapse there because it has to give the atria time to fully contract and empty prior to the ventricles being stimulated. So there's a bit of a delay. Yeah, right there. So anyway, so from the AV node, it goes into the bundle of His. From there, we got, you know, branches off into the right and left bundle branches. And then it goes into the Purkinje fibers, and that's when your ventricles will contract. And each one of these guys, be it the AV node, the SA node, the bundle of His, all those guys actually can pace the heart if there's a failure. So if the SA node fails, the AV node takes over as the heart's pacemaker, and so on and so forth. Now, each one of these guys will pace at its own inherent rate. You notice the SA node is 60 to 100, which we call normal sinus. Then the AV node, if the SA node fails, the AV node will take over, and it'll pace about 40 to 60 beats a minute, and then finally the ventricles will pace about 20 to 40 beats a minute. Now, with an EKG, as we all know, it measures the heart's electrical activity, and it's broken into 5 distinct waves, PQRST. You know, each one of the PQRST parts represents a different phase of the heart. Your P wave is a contraction of both atria, not just one. It's the two atria contracting, and it's the depolarization phase. And like I said earlier, there's a slight pause between the P wave and the Q wave as the two atria is empty. You know, next we have your QRS complex, which is the depolarization of the ventricles, or ventricle contraction, if you will. Your P waves can be absent or small, so an absence of a P wave is not necessarily always a big thing. Obviously, it represents ventricular contraction. Your ST segment is the plateau phase. That's when the heart is in the absolute refractory phase, as I said, when the heart is not susceptible to any stimulation. And the T wave is your repolarization phase. Obviously, PQRST is a complete cardiac cycle. So, come on. Sorry, we're having technical difficulties here, folks. Bear with me on that. And the computer froze. Super. Computer froze. Anyway, the next thing I was going to talk to you guys about is the STEMI itself. So basically putting everything I was talking about together with a STEMI, you have an ST segment at the very end. You know, the S wave comes down and comes back up in positive deflection. So you have an elevation in that. So basically what's happening is somewhere in the heart, one of the arteries that feeds the heart is blocked. So there's a blockage of blood flow to the heart, which is causing ischemia. So basically the heart muscle itself is starting to die due to the lack of blood and lack of oxygen flowing to it. So, and that causes your basic elevation on your EKG. I'm really sorry, the computer froze up here. I wish I could pull this up and show you what I was talking about. Let's see if I can get this to work. All right, let's see if this will actually work. Sorry, everybody. I apologize. Okay, so back to what I was saying. Like I said, the STEMI is an elevation of the S and T waves. It's the earliest sign of an infarction. An infarction, obviously, like I was saying earlier, is an obstruction of the blood supply to an organ, region, or tissue. It causes ischemia, which is dying tissue. Now, with a STEMI, you have to see elevation in leads 2, 3, and AVF, at the very least. So, to just kind of surmise what I was talking about, is an occlusion or blockage of one of the arteries or veins of the heart, causing the heart muscle to die. So basically, what's going on here is there's a block. This person's heart muscle is starting to die. This person is going to die without intervention. Here's some of the other versions of the STEMI you can see in the lead that you'll see it in, like an anterior STEMI. You'll see it, and where the blockage is occurring, which is the left artery, you'll see it in V3, V4, you know, so on and so forth. Now, here's a normal EKG. As you can see, you got your P wave, your QRS complex, your ST segment, and everything. And here's where you have a STEMI. Like I was saying, the S and T wave right here, you can tell is definitely elevated. I know it's kind of a textbook thing, and you'll probably never see that realistically in the field, but that's a general idea of what it looks like. And basically with the treatment, you know, obviously we normally transport to Newman's. They open up the blocked artery with a balloon or an angioplasty, and they put a stent in there and hold open the vein. And obviously every second counts. Time is muscle. All right. I just kind of want to tell one quick story. Sam and I ran a call one day to Jacobs Creek. This lady called having a diabetic emergency and actually was going to refuse. And Sam, doing a thorough assessment, put her on the monitor, and turned out the lady was having a STEMI. She had no other complaints but her blood sugar. So my point is always maintain a high index of suspicion and always be thorough. It takes 2 seconds out of our day to put someone on a monitor. I'm not saying we have to put someone with knee pain on the cardiac monitor, but with a lot of times, if you maintain that level of suspicion, you want to just keep them, take a look. It takes no time out of our day to actually take the time out to assess our patient thoroughly, even if it is only going to be a refusal. So, BS turns into very quickly, as we all know. So things can go pear-shaped on us. So just always be alert and maintain your index of suspicion. And that's all I got. Thanks for your time, guys.
Thank you, Joe. Very good.
So anyway, I got to do this one more time, and then Sam can take over. Yeah. Sorry, Sam. Yeah, I'm done.